Good morning, everybody. I am Dr. Gnananandhar, Associate Professor, Department of Dentistry, Sri Lakshmi Narayana Institute of Medical Sciences, Puducherry, affiliated under Bharat Institute of Higher Education and Research, Chennai. Today, my topic is about molecular etiopathogenesis of ameloblastoma. Before starting the introduction, I would like to expand the topic in detail. What is molecular pathogenesis? Molecular pathogenesis is nothing but the alteration of molecules that occur in response to environmental insults and certain contributing factors that produce pathology. This pathogenesis of ameloblastoma is a multifactorial and involves numerous cellular pathways. Diverse types of molecules and genes altered. Another important criteria involved in the structure is cell cloning. What is cloning? Cloning is a process of making identical copies of organisms, cells, DNA sequences. And this is the clinical picture of ameloblastoma and the panoramic view. Now the introduction. Ameloblastoma is second most common benign epithelial odontogenic tumor. The clinical presentation: solid, multicystic, unicystic, desmoplastic, and peripheral types. The pattern of arrangement of tumor cells. It is arranged in follicular, plexiform, acanthomatous, granular, basal cell types. And histological resemblance. The epithelial odontogenic apparatus resembles enamel organ and dental lamina. In some respects, a detailed mechanism of oncogenesis, cytodifferentiation, and tumor progression remains unknown. And about its clonality. Most odontogenic tumors are monoclonal in nature. An initial mutation and molecular alterations is just first event in the development of tumor. The sequence of events remains unknown. Stem cell related molecules. Kumamatol in 2010 analyzed stem cells of related molecules CD133 and BMI1. They show a positive expression in two germs. The reactivity of ameloblastomas and metastasizing ameloblastomas. The most of the neoplastic cells in clear cell odontogenic carcinoma and ameloblastic carcinoma. Increased expression of CD133 in malignant ameloblastomas. This ATP binding site G2 is absent in two gems but shows a strong expression in malignant ameloblastomas. The role in cell differentiation, oncogenesis, and malignant potential of odontogenic epithelium. Next is about CD133. It is an antigen also known as prominent 1. It is a glycoprotein. CD133 has been used extensively as a marker for the identification of stem cells from normal and cancerous tissue. And next is about follicular type. This is the analysis of immunoexpression of common cancer stem cell markers in ameloblastoma. Next is about BMI1. It's a proto-oncogene, otherwise called polycomb ring finger. This is a protein coding gene, and its location is 10th chromosome, P arm, segment 1, band 1, subband 2 and 3. Next is ATP binding site G2. It is a protein coding. This protein functions as a xenobiotic transporter, which may play a major role in multi-drug resistance. And its location, 4th chromosome, Q arm, segment 2, band 2. Next is about cell adhesion molecules. In 2007, Leocata et al. Conducted a study in intraosseous ameloblastomas. The syndicate 1 might be the reason for the local invasiveness of some intraosseous ameloblastoma subtypes. Bologna and Molina in 2008 They suggested syndicate 1 in solid ameloblastoma and the involvement of syndicate in unicystic ameloblastoma. Ataibi in 2013 studied about syndicate 1. It shows an immunoreactivity in the stromal cells of ameloblastoma, keratocystic odontogenic tumor, and dentigerous cyst, and there's a decreased expression of syndicate 1 associated with poor prognosis of the lesion. And the syndicate, otherwise known as CD138, the syndicates mediate cell binding, cell signaling, cytoskeletal organisms. The syndicate 1 protein functions as an integral membrane protein and participates in cell proliferation, cell migration, and cell matrix interaction via its receptor for extracellular matrix proteins. Altered syndicate 1 shows the expression has been detected in several different tumor types and its location. Second chromosome, P arm, segment 2, band 4, subband 1. In 1991, Iken Hemo, he discussed about alpha 5 beta 1 integrin. It is a greater migration capacity with fibronectin expression in stromal cells. Later, in 2007, Souza studied the role of alpha 5 beta 1 integrin in ameloblastoma and adenomatoid odontogenic tumor. It shows increases the secretion and expressions of metalloproteinases. Integrin alpha 5 beta 1. Integrins are transmembrane heterodimeric proteins sensing the cell microenvironment and modulating numerous signaling pathways. Changes in inter-expression between normal and tumor cells support involvement of specific integrins in tumor progression and aggressiveness. In 2010, Gonzalez suggested the role of protoplanin. It represents lymphocytic specific marker, tumor-induced platelet aggregation, tumor metastasis, and also with tumor invasiveness. Next is about protoplanin. It's a protein coding gene. The associated binding sites are T1A, GP36, GP40, GP38, O2S8, T1A2. This gene encodes a type 1 integral membrane glycoprotein with diverse distribution in human tissues. The physiological functions of this protein may be related to its mucin type character and its location. Chromosome 1, P arm, segment 3, band 6, subband 2 and 1. In 2011, Ribeiro studied expression of metallothionein in ameloblastoma and calcifying epithelial odontogenic tumor. He found significantly higher expressions in ameloblastomas. It is a reservoir of zinc for proteases such as matrix metalloproteinases, and it has anti-apoptotic features in the tumor. In 2014, Johan found an expression of metallothionein in solid ameloblastoma, and they correlated it with the clinical behavior of local invasiveness and high rate of recurrences. Metallothioneins. Metallothioneins are encoded by multi-gene family in man. It is expressed in primary human fibroblast. Matrix metalloprotein, a group of enzymes which is responsible for the degradation of most extracellular matrix proteins during organogenesis, growth, and normal tissue turnover. These MMPs have a marked role also in tissue destruction in oral diseases. Ameloblastin and other enamel matrix proteins. Expression of ameloblastin, sheathulin, and enamelin protein absent in ameloblastoma. The ameloblast cells not attain functional maturation in tumor cells. In 1992, Sneed found that amelogenin described differentiated ameloblast, which is expressed by ameloblast epithelial cells. In 2000, Toyosawa reported potential mutations in ameloblast transcripts not primarily related to the development of ameloblastoma. In 2004, Perdigao found a mutation in ameloblastin gene in epithelial odontogenic tumors. Deficiency of amyloblastin, deregulation of amyloblast differentiation, cause of the tumor. Molecules involved in cell cycle proliferation, that is Ki67. In 2012, Flosque, he suggested Ki67 in peripheral cells when Ki67 central cells, suggesting that proliferative in tumor island is similar in both unicystic ameloblastoma and solid ameloblastoma. Despite some difference in various subtypes, the highest nominal unicystic ameloblastoma with stellate reticulum-like cells compared with the other subtypes. K69 shows positivity in basal and parabasal layers. The expression of the human K67 protein is strictly associated with cell proliferation. During interphase, the antigen can be exclusively detected within the nucleus, whereas in mitosis, most of the protein is relocated to the surface of the chromosomes. Present during all active phases of the cell cycle, growth phase 1, synthesis phase, growth phase 2, and mitotic phase, but it is absent from resting cells. Excellent marker for determining the so-called growth fraction of a given cell population. The fraction of Ki67 positive tumor cells is often correlated with clinical course of the disease. Proliferating nuclear cell antigen. Its expression is more in unicystic ameloblastoma compared to solid ameloblastoma. Funaka et al. He suggested PSNA labeling index for follicular ameloblastoma is greater than plexiform ameloblastoma. In 1989, and Ricard in 1995 also stated that the high expression of PCNA in follicular ameloblastoma can explain its increased potential of recurrence. But Cell-Hingard in 2011 found the highest mean index of positivity for PCNA in acanthomatous ameloblastoma. Malignant transformation. Recurrence is determined by PCNA values. It shows expression from unicystic ameloblastoma. It's greater than follicular ameloblastoma, and it is further greater than plexiform ameloblastoma. The maximum positivity is seen in ameloblastic carcinoma. Lee et al. And Shear et al. Stated Ki67 and PCNA are the markers for recurrence and aggressiveness of the tumor. This proliferating cell nuclear antigen, it's a protein coding. The associated gene resulting from defects in DNA excision repair. The protein encoded by this gene is found in the nucleus and is a cofactor of DNA polymerase delta. It helps in strand synthesis during DNA replication and DNA repair pathway. And its location, 20th chromosome, P arm, segment 1, band 2. This is the histology section of the follicular ameloblastoma, showing strong nuclear staining for PCNA. Next is about cyclin D1. Nuclear and cytoplasmic expression of cyclin D1 was predominantly seen in both peripheral cells and stellate reticulum-like tissues. Its role in proliferation, peripheral cells, and differentiation in central cells. Cyclin D1, it's a protein coding. The associated sites BCL1 and BRAD1. They both interact with tumor suppressors protein, retinoblastoma, and the expression of this gene is regulated positively by retinoblastoma gene. The mutations, amplification, overexpression of this gene, which alters cell cycle progression, are observed frequently in a variety of tumors and may contribute to tumorigenesis. This is the immunohistological a picture which shows the expression of cyclin D1 in ameloblastoma. Next is about telomerase enzyme. It involves in the proliferative potential of ameloblast cells. Telomerase reverse transcription suggested that c-Myc might induce the telomerase activity in ameloblastomas. It shows a high expression of human telomerase RNA. HTRT was closely related to the clinical behavior of ameloblastoma and regulated by p53. c-Myc, it is a proto-oncogene protein, a transcription factor that binds DNA in a non-specific manner, activates the transcription of growth-related gene. Next is about follicular ameloblastoma. This is the histology picture of the follicular ameloblastoma. c-Myc oncogene expression in selected odontogenic cysts and tumors and immunohistochemical study. Growth factors. Epidermal growth factors receptor levels in ameloblastoma is increased when compared to radicular cyst, suggested their role in tumorigenesis. Hepatocyte growth factor and c-Met signaling pathway, it show increased expression in ameloblastic carcinoma and clear cell odontogenic carcinoma, amplifying their association with malignant potential of epithelial odontogenic tumor. c-Met, its full name, Met proto-oncogene receptor tyrosine kinase. The gene type is protein coding, also known as hepatocyte growth factor receptor. The proto-oncogene MET produced the product is the hepatocyte growth factor receptor and encodes tyrosine kinase activity. Its location, 7th chromosome, Q arm, segment 3, band 1. The immunohistochemistry evaluation of fibrous growth factor 1 and 2 showed similar staining in ameloblastoma and normal dental follicles, whereas intense reactivity seen in the cytoplasm of cultured ameloblastoma epithelial cells. Ameloblast-like cells and the cells of stellate reticulum-like tissue presented high expression of fibrous growth factor 1, and whereas fibrous growth factor 2 was seen in basement membrane, implying their distinct roles. Further studies are needed to confirm their role. PDGF-A isoform and its receptor PDGF alpha receptor levels were more in malignant ameloblastic tumors when compared to non-metastatic ameloblastoma. The prostaglandin growth factor ligand and receptor system participate in malignant transformation of odontogenic epithelium. PDGF, phosphatase and tensine bonding, it's a protein coding. The associated site BZS and DC. This gene was identified as a tumor suppressor that is mutated in large of cancers at high frequencies. Its location, 10th chromosome, Q arm, segment 2, band 3, subband 3. And next is about apoptotic markers. In 1999 and 2004, Kumamoto suggested BCL2 family proteins with associated BCL2, BCLX. They are the inhibitors of apoptosis in neoplastic cells neighboring the basement membrane, suggesting their role in suppression of apoptosis in those cells. Later in 2005, it was observed that the expression of apoptotic protease activating factor 1, cytochrome C, apoptosis inducing factor, and capsase 9 in 2 germ and ameloblastomas, and it was suggested that apoptotic cell death of normal and neoplastic odontogenic epithelium is by mitochondrial mediated apoptotic pathway. Increased apoptotic cell death in keratinizing cells in acanthomatous ameloblastoma. Granular cell ameloblastoma variants and neoplastic cells of ameloblastic carcinoma was found, suggesting their role in cytodifferentiation and malignant transformation of odontogenic epithelium. In 2006, Low et al. He studied FAS and FASL have a role in the disposal of terminally differentiated or degenerative tumor cells in ameloblastomas. Many studies conducted on apoptosis I and apoptotic protein and cell proliferation markers were expressed in the peripheral basal cell layers of ameloblastomas, reason for their progression. FAS cell surface death receptor, it's a protein coding, is otherwise known as CD95. The protein encoded by this gene is a member of the tumor necrosis factor receptor superfamily. This receptor contains a death domain. It has been shown to play a central role in the physiological regulation of programmed cell death and has been implicated in the pathogenesis of various malignancies and diseases of the immune system. And its location, 10th chromosome Q arm, segment 2, band 4 and subband 1. Tumor suppressor gene. It is otherwise known as guardian of genome or policeman of genome. This P53 abbreviated of P14AR of MDM2 P50, which forms a cascade, this strongly correlates with neoplastic transformation. Kumama et al. In 2004 found an elevated expression of P14AR of MDM2 P53 is benign and malignant ameloblastomas. He suggested the alteration of P14AR of MDM2 and P53 cascade leads to oncogenesis or malignant transformation of autologenic epithelium and also associated with tissue structuring and cytodifferentiation of ameloblastomas. Next comes the retinoblastoma. In 2006, Kumamoto studied the retinoblastoma and phosphorylated retinoblastoma, ameloblastoma, then in two germs. There's a role in cell proliferation and differentiation of odontogenic epithelium. Another study by Lim and Han et al. In 2006, using DNA microarray and reverse polymerase chain reaction, revealed downregulation of retinoblastoma 1 in ameloblastoma in comparison with a lentiginous cyst. P10. Shipper in 2008 found there's a decreased expression of P10 in ameloblastoma compared to dental follicle and elucidated the role of PTN, AKT, mTOR pathway in pathogenesis and aggressiveness of ameloblastoma. In 2010, Shen studied immunohistochemistry expression of osteonectin and secreted and matrix metalloprotein 1, 2, and 9 in 23 cases of ameloblastoma. Found an association between SPARC and matrix metalloprotein 9, MMP2, and 9 degrade type. Type 4 collagen components of basement membrane. Hence, lesions with matrix metalloproteins show more invasive behavior. In 2004, Abdel Sayed found an increased expression of parathyroid hormone related proteins in ameloblastoma. Its role in local bone absorption, role in infiltrative growth and destructive behavior of ameloblastoma. In 2004, Kumamoto analyzed the expression of ODF, RA-NKL, and OCL, osteoprotein, parathyroid receptor protein in ameloblastoma, and tooth germs observed that these factors regulate bone metabolism and dynamics in tooth as well as prognosis of ameloblastoma. Also found their involvement in tumor cell differentiation and tumor structuring in ameloblastoma. In 2005, Sandra et al. Found that the RA-NKL tumor necrosis factor alpha secreted by ameloblastoma cells could induce the osteoclastogenesis, which in turn provide space for it to expand. Other signaling molecules. the PTCH1 gene encodes a receptor for sonic hedgehog. This sonic hedgehog regulates growth and determines the shape of the tooth, but its signaling is not essential for the differentiation of ameloblast or odontoblast. In 2004, Kumamoto found lower expression of sonic hedgehog in stromal cells compared with the mesenchymal cells in tooth germ. PTCH1 protein patched homolog 1 acts as a receptor for sonic hedgehog, seems to have a tumor suppressor function. Inactivation of this protein leads to tumorigenesis. In 2006, Zhang et al. Found strong cytoplasmic expression of sonic hedgehog in cellular components of the neoplastic tissue, mainly located in peripheral or cuboidal cells, that they regulate the proliferation of tumor epithelial cells. Rao et al. In 1997 conducted a study on IHC in 20 cases of ameloblastoma to determine the expression of bone morphogenic protein. Although it showed a positive expression of ameloblastoma of tooth germs, has no detectable levels of bone morphogenic protein found in immature tumor cells. In 2006, Kumamoto and Uya revealed the expression of bone morphogenic protein 2, 4, and 7, and bone morphogenic protein receptor 1 and bone morphogenic protein receptor 2 in ameloblastoma samples. In all types of ameloblastoma tested, bone morphogenic proteins and their receptor were identified. Immunostaining for these molecules was observed in neoplastic cells neighboring the basement membrane of the tumor, suggesting their role in the cytodifferentiation of neoplastic odontogenic epithelium. In addition, in keratinizing cells of acanthomatous aminoblastoma, there was a strong reactivity for bone morphogenic protein 7, which suggests its association with cell death of neoplastic odontogenic epithelia. WNT pathway suggested to occur in oncogenesis. Beta-catenin found in the cytoplasm and membrane of most neoplastic cells of ameloblastomas and associated with signal transduction and cell-to-cell adhesion the neoplastic odontogenic epithelium. Kumamoto and Oyo in 2005, they both found nuclear beta-catenin expression in some ameloblastomas, but it was not identified in tooth germ. In 2008, Alaidini studied the expression of calretinin in 55 odontogenic tumors, including ameloblastoma, adenomatoid odontogenic tumor, calcifying epithelial odontogenic tumor, ameloblastic fibroma, and odontogenic myxoma. It was expressed only in ameloblastoma. Another study by Sirisha in 2010, she suggested calretinin expressed only in stellate reticulum-like cells in solid ameloblastoma and unicystic ameloblastoma. Thus, calretinin specific IHC marker for neoplastic ameloblastic epithelial, which is expressed only in solid ameloblastoma and unicystic ameloblastoma, but not in any other odontogenic cyst or tumors, used as a diagnostic marker to differentiate unicystic ameloblastoma from other cystic lesions. And this is the concise tabular column of the markers and their expression and their suggestion. ABCG2 CD33 BMI1 shows the increased expression in ameloblastoma and is suggestive of oncogenesis, cell differentiation, malignant potential. The syndicane 1 shows a decreased expression in ameloblastoma, suggestive of aggressiveness and invasiveness. The alpha 5 beta 1 integrin shows increased expression in ameloblastoma, suggestive of invasiveness. Photoplanin shows increased expression in ameloblastoma and suggestive of invasiveness. Metallothionein shows the increased expression in ameloblastoma and suggestive of invasiveness, high recurrences. The Ki67 shows increased in peripheral cells, suggestive of aggressiveness. PCNA shows increased expression in unicystic ameloblastoma, follicular ameloblastoma, plexiform ameloblastoma, ameloblastic carcinoma, suggestive of recurrences and aggressiveness. Cyclin D1 shows increased expression in ameloblastoma, suggestive of invasiveness, aggressiveness, poor prognosis, lymph node metastasis. Hepatocytic growth factor and CMET shows increased expression of ameloblastoma and suggestive of malignant transformation. Anti-apoptotic markers, BCL2, BCLX in the peripheral cells shows a cytodifferentiation and malignant transformation. FAS, FACL in certain cells in acanthomatous and granular cell ameloblastoma shows cytodifferentiation. P14AR of MDM2 and P53 cascade shows increased neoplastic transformation. Retinoblastoma increased differentiation, cell proliferation. P10 shows increased expression and suggestive of aggressiveness. Matrix metalloprotein 1, 2, and 9 shows increased expression in ameloblastoma and suggestive of aggressiveness and invasiveness. The parathyroid hormone receptor P shows increased expression in ameloblastoma, suggestive of infiltratory growth and destructive behavior. The marker RANKL and tumor necrosis factor alpha shows increased expression in ameloblastoma and suggestive of osteoclastogenesis, tumor expansion. PTCH1 shows increased expression in ameloblastoma and suggestive of proliferation of odontogenic epithelium. Bone morphogenic protein 2, 4, and 7 shows increased expression of ameloblastoma and cytodifferentiation of apoptotic cell death. B-catenin shows increased expression in ameloblastoma, suggestive of cell migration. Now the general discussion. Tumors are new growth of abnormal tissue in the body. They are broadly classified as benign and malignant depending on their behavioral pattern and cellular structure. Benign jaw tumors are broadly divided into odontogenic tumors, non-odontogenic tumors. Odontogenic tumors may be derived primarily from the epithelium, predominantly from mesenchyme. A mixed group, both epithelial and mesenchymal tissue shared in the formation of a lesion. Now the classification. Epithelial odontogenic tumor, ameloblastoma, calcifying epithelial odontogenic tumor, adenomatoid odontogenic tumor, squamous odontogenic tumor, and calcifying odontogenic cyst. Next, the connective tissue odontogenic tumors. Odontogenic fibroma, intraosseous desmoblastic fibroma, peripheral odontogenic fibroma, central odontogenic fibroma, odontogenic myxoma, and cementoblastoma. Now next, mixed odontogenic tumors. Under mixed odontogenic tumors, ameloblastic fibroma, odontoma, ameloblastic fibro, odontoma. Under malignant odontogenic tumors, ameloblastic carcinoma, malignant ameloblastoma, odontogenic carcinoma, primary intraosseous carcinoma. Next, epithelial odontogenic tumors. Ameloblastoma. It is a true neoplasm of benign origin and with persistent lesion. Its pathogenesis, cell rests of enamel organ, developing enamel organ, basal cells of the epithelium, the heterotrophic epithelium, especially the pituitary gland, epithelium of odontogenic cyst. Next is clinical features. Benign invasive lesion, osteoclastic resorption, occurs between the age of 20 to 50 years and more frequently in mandible with swelling, pain, and superficial ulceration. The maxillary tumor exhibits nasal obstruction, bleeding, trismus, and maxillary sinus involvement, with enlargement of the mandible and increased transverse diameter. And this is the clinical picture of ameloblastoma. Here, the picture exhibits left swelling on the buccal area, and the panoramic view also exhibit the soap bubble appearance. And in this clinical picture, there is a swelling in the right side of the face, and the panoramic view shows a soap bubble appearance. Next is about radiological features. Multilocular appearance, honeycomb or soap bubble configuration, scalloping of the inner cortex, large tumors with complete loss of bone, and the classification according to radiological features: multilocular, multicystic, unilocular, septate, trabeculated, solid type. And the differential diagnosis: dentigerous cyst and residual apical periodontal cyst, primordial cyst, fibromyxomas, giant cell granulomas, osteoblastoma, brown tumor of hyperparathyroidism, odontogenic keratocyst, calcifying epithelial odontogenic tumor. Histopathology: follicular type, plexiform type, intraluminal, mural, and invasive type. And next is about the treatment: curettage, excision, end block resection, segmental resection, cautery, radiotherapy. And next is about pinbock tumor. Its pathogenesis: it arises from reduced enamel epithelium of unerupted teeth. Then their clinical features: expansile, painless mass, slow growth rate, occur at any age, molar mandible, it is the commonest region. Radiographic features: radiolucent, unilocular, or multilocular lesions. There are 3 stages similar to dentigerous cyst and cannot be differentiated radiographically. Minic calcific. And next is about histopathology: sheets of polygonal epithelial cell. Cytoplasm is abundant and eosinophilic. Differential diagnosis: dentigerous cyst, odontogenic keratocyst, ameloblastoma, odontogenic myxoma, ossifying fibroma, osteoblastoma. And the treatment: enucleation and excision. And next is about adenomatoid odontogenic tumor. Its pathogenesis: it derives from the cells of inner enamel epithelium at the pre-ameloblastic stage. Its clinical features: asymptomatic, slow-growing swelling, most commonly occurs in maxilla, and it is a benign encapsulated lesion. Its radiographic features: well-demarcated radiolucency, sclerotic margins, faint irregular radiopacities, and root resorption. Histopathology: epithelium arranged in strands, sheets, and whorled masses. Cuboidal columnar cells forms rosettes of duct-like structures. Its treatment: curettage or enucleation. And next is about adenomatoid odontogenic tumor. This is the clinical picture of adenomatoid odontogenic tumor. This is the exposed area, and the other panoramic view shows the translucency in the anterior located near symphysis menti. This is the exposure of the lesion, and the next picture shows the enucleation after the, and next picture shows the enucleation. Squamous odontogenic tumor. Its clinical features: anterior to molars, both maxilla and mandibular involved. It occurs at any AHP, third decade. It is a painless swelling or loosening of tooth. Next is radiologic. Small ones are unilocular radiolucencies. Large ones have multiloculated distinct border, and tooth separation is common. Squamous odontogenic tumor. The treatment. Small lesions can be exist by curettage. The large one can be done with block resection. Next is connective tissue origin. Central odontogenic fibroma. It is a rare lesion, counterpart to peripheral odontogenic fibroma, seen in all age groups and found in both mandible and maxilla. It is a radiolucent lesion, multilocular cortical expansion. Treatment is excision and recurrence is unexpected. Next is about odontogenic myxoma. It is a mesenchymal organ. It belongs to benign category that may be infiltrative and aggressive. It is mostly seen in maxilla and mandible, occurs between the age 10 to 15 years, and it has radiolucent, well circumscribed lesion. Honeycomb pattern is seen on the panoramic view. And the treatment plan is excision. And next is about cementoma. It is a complex calcified tissue, contains cellular or acellular cementum. Periapical cemental dysplasia occurs at the apex of the vital teeth. Diagnosis by clinical and radiological features. Differential diagnosis of sclerosing, osteomyelitis, and Paget's disease. No treatment required. Next is cementifying fibroma. It occurs in the mandible, more towards females, may cause tooth movement or cortical expansion. It has radiolucent lesion, enucleation or excision, and recurrence is unexpected. Next is cementifying fibroma. It occurs in the mandible, more towards females, and may cause tooth movement or cortical expansion. It is a radiolucent lesion. Enucleation or excision or recurrence is unexpected. Dentinoma is a compost predominantly of dentin with soft tissue and cementum and no enamel is present. There are two types, fibro-ameloblastic type and mature type. An intermediate form of odontoma formation occur in mandible molar region with no sex prediction. The common treatment is curettage. And next is dentinoma. It is composed predominantly of dentin with soft tissue and cementum and no enamel. Two types, fibroblastic type, mature type, an intermediate form of odonto formation occur in mandible molar region with no sex prediction. Treatment by curettage. And next is mixed odontogenic tumors. It is ameloblastic fibroma, soft tissue odontoma, slow growing unilocular or lobulated cavity. Pathogenesis, epithelial origin, tumor-like proliferation of connective tissue. And next is clinical features. Average age 15 years, both sexes are commonly affected and occur in posterior region of the mandible. Next is radiological features. It is a radiolucent lesion, occurs in ramus of the mandible. Next is histological features. It strands and sheets of epithelial cells ramify, stellate appearance. The known treatment, curettage or enucleation. And next is about ameloblastic fibroodontoma. It's abnormal proliferation of odontogenic epithelium. Expansile lesion grows slowly with swelling, mild pain, altered occlusion, and delayed eruption of teeth. Radio-opaque circumscribed cavity in bone with smooth, even borders. The known treatment is curettage. Next is odontoma. It's a benign tumor of dental hard tissue. Composite means the presence of four dental tissue, that is enamel, dentin, cementum, and pulp. Occur anywhere in the jaw, more frequently in third molar, incision, and canine region. It is slow growing and asymptomatic. Next is compound composite odontoma. It is a calcified structure with unknown etiology. It is developed from the enamel organ or dental lamina or supernumerary lamina. Clinical features. It occurs in anterior region of jaw. It is of non-aggressive, self-limiting growth. It occurs in 2 to 3 decades of life. Next is radiological feature. It is a multiple opaque masses situated between primary and permanent dentition with follicular capsule. Pathological features. Numerous dwarfed teeth, malformed crowns and roots. Common treatment, enucleation. Next is complex composite odontoma. Calcified mass displaying a disorderly pattern of hard tissue. Its clinical feature. It occurs in second and third molar region in 2 and 3 decades of life. It occurs as a small lesion. Its radiological features. Nodular radio opacity and thin radiolucent periphery. Next is histopathological features. Enamel matrix, dentin, dentinoid, pulp tissue, and cementum are arranged unevenly. Differential diagnosis: focal sclerosing osteomyelitis, osteoma, periapical cemental dysplasia, ossifying fibroma, and cementoblastoma. The common treatment is enucleation and curettage. Next is about complex odontoma. This is the picture of complex odontoma. Shows the incision area. And the OPG reveals the radio opacity of the posterior region. And first picture shows the exposure. The second picture shows the removal of odontoma. The first picture exhibits enucleated socket, and second one exhibits the specimen. And next is about malignant odontogenic tumors. Odontogenic carcinoma. Primary intraosseous carcinoma. It is a rare malignancy, develops in bone from odontogenic epithelium. And the commonest site is mandible. Male predominantly affected than female. Response better to radiation therapy. Cells are arranged in plexiform manner with palisading of the peripheral cells. Treatment by local surgical excision, resection of the mandible and en bloc dissection of the lymph nodes of the neck, and radiation therapy. And next is malignant ameloblastoma. The primary malignant ameloblastoma becomes malignant by alteration in structural and biologic qualities. It occurs in older age group. And metastasis by the lymphatics and blood vessels. And regional lymph nodes are the most frequent site. Ameloblastic carcinoma. It is the aggressive neoplasm of the mandible or maxilla in which The epithelial cell exhibit cytological features of common ameloblastoma and malignancy. It differs from ameloblastoma in that portion of its epithelial component are composed of cytological malignant cells. Yet the lesion is still readily recognizable as ameloblastoma. The histological features pattern the aggressive behavior of the lesion. If metastasis is not present at discovery, surgery is required to prevent this eventually. Primary intraosseous carcinoma. A squamous cell carcinoma within the mandible or maxilla with no indication that it originates from the surface epithelium or that is metastasized from another one. Here root resorption takes place and it invades nerve trunks. And metastasis regionally and distant sites commonly arise from pre-existing odontogenic cyst like dentigerous cyst. The common treatment: regional neck dissection, surgery followed by radiotherapy. Next, some oncology treatments. Radiation oncology. Radiotherapy can be considered in patients who are medically unfit for surgery. Different modalities have been used, including tomotherapy, proton beam therapy, imaging guided radiotherapy, and intensity modulated radiotherapy. Some of them have been used as a combined treatment with surgery or chemotherapy. Their use is recommended when treating ameloblastic carcinoma or recurrent ameloblastoma after multiple surgical excision. However, studies show mixed responses when using them as an adjuvant treatment with or without chemotherapy. Risk should be discussed with the patient, including the potential of life-threatening malignant transformations. The next is about medical oncology. Chemotherapy. The efficacy of chemotherapy in the management of primary and recurrent ameloblastoma is still controversial. Many drug regimes have been used with surgery and or radiotherapy. This includes the following combinations: adriamycin, cisplatin, and cyclophosphamide, vinblastine, cisplatin, and bleomycin, gemcitabine, carboplatin, and doxorubicin, and cisplatin. However, more high-quality randomized control studies are needed to validate their use. Targeted therapy. Recent understanding of the molecular basis of the development of odontogenic tumors, especially ameloblastoma, led to the development of targeted therapies. Many MAPK specific drugs have been introduced. This includes BRAF inhibitors such as vemurafenib and defrafinib. MEK inhibitors like trametinib and FGFR2 inhibitors such as ponatinib and regorafenib. In general, MEK inhibitors are better when compared with BRAF inhibitors, as the latter effect may be the compensatory activation of the MAPK pathway by epidermal growth factor receptors. Similarly, different drugs have been manufactured to target the SMO mutation associated with ameloblastoma. This include bismuth, and itraconazole. However, some resistance mechanism against these drugs have been reported. Moreover, several drugs have been made to antagonize sonic hedgehog signaling pathway. The most widely used one is cyclopamine, but its main side effect is impairment of bone healing as it suppresses osteoblastic proliferation and differentiation. Next is about prognosis. The approximately treated with surgical excision, benign tumors have a low recurrence rate, except for ameloblastoma, which has a recurrence rate of 10 to 20% according to histological subtypes. While the majority of malignant odontogenic tumors are either malignant ameloblastoma or odontogenic carcinoma. The improved survival rate is associated with an age of under 57 years, lack of comorbidities, surgical resection, and absence of nodal disease. The 5-year overall survival for surgical excision is around 88% compared with 26.6% for non-surgical management. The presence of lymph node metastasis is always associated with a poor prognosis. And next is about complications. The complications can be either related to the tumor or surgical management. Gradual expansion of the tumor may lead to mandibular maxillary distortion, leading to facial asymmetry, pain, teeth displacement, malocclusion, or recurrence. Distance metastasis can be seen in cases of malignant tumors. Lungs and cervical lymph nodes are the most affected sites. At the same time, some surgical complications may be in the form of post-operative bleeding, which may be quite significant as it will endanger the airway patency, infection, neurosensory disturbance due to inadvertent injury of the inferior alveolar nerve. Other general complications may also occur, including aspiration, deep venous thrombosis, and pulmonary embolism. All necessary post-operative measures should be taken to avoid the occurrence of these complications. Deterrence and patient education. It is important to educate patients on the natural history of different odontogenic tumors and highlight the red flags to look for, such as rapid growth, neurosensory changes, pain, and neck masses. In addition, educating the patients on how to examine themselves and keeping regular follow-up is crucial for early detection of any possible recurrence or malignant transformation. Enhancing healthcare team outcomes. It is mandatory to treat odontogenic tumor in an interprofessional team approach to ensure proper treatment and outcome. The team should include an oral surgeon, head and neck surgery with proper expertise in neck dissection. Having a plastic surgeon in the team is also important in cases when possible reconstruction might be needed. Post-operative care is crucial for optimal outcomes. Nursing staff should look after the airway, make sure it is clear and patterned by frequent suctioning to prevent aspiration and maintain good oxygenation. Prophylactic measures should also be taken to avoid potential risk of deep venous thrombosis or stress ulcers. Pain team involvement in the early post-operative period can significantly improve the overall patient treatment experience. Dietitian may be needed for early post-operative care for patients struggling with oral feeding or who have been instructed not to eat to heal the surgical site. In these cases, parenteral nutrition may be considered. Speech and language therapist plays a great role in the rehabilitation of surgical patient to improve their long-term outcome. When an operation involves major resection with significant cosmetic consequences, care should be taken to involve mental health nurses to counsel the patients and provide the needed support. Although the surgical option is the main treatment in most cases, few cases may benefit from radiotherapy or chemotherapy. In such cases, the involvement of the oncology treatment is mandatory. All team members should keep good communication to ensure that the best possible outcome could be achieved. So finally, I conclude the development and progression of ameloblastoma can be affected by alteration of many kinds of genes and molecules. Further molecular studies, including genomic, proteomic based prolifing, are required to clarify the etiology and pathogenesis of ameloblastoma. A better understanding of underlying molecular mechanism will help to predict the course of ameloblastoma and lead to the development of new therapeutic complications such as molecular targeted treatment and patient tailored therapy. Thank you.